All right, everybody, happy Monday, and thanks for stopping by for the pre-hospital case study of Grander lesson of the week for August 17th, 2014. Several good cases and a really good topic to cover today, so I'm really happy that everybody could stop by. Remember, share this with all your friends and colleagues that's in pre-hospital services or emergency medicine. We're trying to build up our viewer base. We're up to about a couple hundred viewers a week. We used to get about 500 viewers a week when we were the pre-hospital project. So we're really getting up there. Thanks for all your support. Come back every week and share this with everybody you know. Another update on the website. No live updates have been done, but I've been working behind the scenes as best I can for the last couple weeks. Vacation's coming up. I plan on lounging in many different places, working on the website, hopefully getting several more pages live within the next few weeks. Probably by mid-September, a couple sections will be live that are not live currently. Without any other ado, we're going to start with the introductory case for August 17th, 2014. So the call is for a 67-year-old male who is unconscious and possibly in cardiac arrest. They're giving CPR instructions. So when you arrive, the man is awake, pale, diaphoretic, not in cardiac arrest, talking to you. He's on oxygen and is able to tell you, he just thinks that he passed out, but staff is certain he turned blue, stopped breathing, had no pulse, but they did 30 seconds of CPR and the patient woke up. So probably not in cardiac arrest. He was not defibrillated. He didn't get any epinephrine. Unlikely that this patient was in cardiac arrest, but clearly something had happened to him. Vital signs are okay, not very tachycardic, not extremely hypotensive, but worrisome. Good saturation on low flow oxygen. Respiratory rate just slightly elevated, as is the glucose. He has a history of diabetes, renal failure, etc. The patient complains only of weakness and tiredness, which he's felt for several days. But he's very pleasant, completely awake and oriented, and able to answer all questions appropriately. So you attach the EKG, and this is what you see. So you go through whatever algorithm that you normally follow to decide what a rhythm is. So mine is it fast or slow? Well, it's not really either. If you look at right here where this QRS starts, we're on this line. So this line would be 300, this line would be 150, this line would be 100. So this rate is actually slightly less than 100, and we already established that the heart rate was 90 during our vital signs assessment. Next, you decide if this patient is in a sinus rhythm or what the origin is, and there's no P waves. It's very regular. There's no flutter waves. So it appears that it would be not a supraventricular rhythm. Is it VTAC? As we all know, VTAC has to be 120 or higher, generally accepted. Excuse me. And this patient, as we just found out, was in the high 90s, doesn't break 100, so it's unlikely to be VTAC. So a good settling would be that the patient's in an accelerated junctional rhythm. That would be something that I could say, okay, I'll buy that for a while until we do a little more investigation. Just in case, I know this is a bad quality EKG. I was so excited when we took it. It was me and my partner Jeff and I that were on this call. And I was so excited when I got the EKG. I've been carrying it around in my bag, meaning to do this podcast. I wanted to make it the next lesson, but it kind of faded over time, and it's just not in the EKG to reprint out anymore in the machine. So we have to deal with this EKG because it's too good to pass up. I don't want you to have to imagine anything, but later when we review the case, I will highlight some things that I can see more clearly by having the EKG present with me on my desk that isn't translating well to the scan. I've tried scanning it multiple times with different machines, and it's just not good quality because it's so faded. So you can take a little look at the lower EKG, which has a blow up of a section of it. You can see that there's no P waves. It's very regular. The rate's less than 100. So an accelerated junctional is a good thing to settle on. There's a couple other things on this EKG that people with hawk eyes might be able to come across, and we will talk about that later, but I'm not going to mention it right now. So uh, if you think about when you put this EKG on somebody, you have to do a 12 lead. So we do the 12 lead. Here's Bertram, our little friend. He sits inside the heart monitor and he tells us what he believes that the monitor is. And his interpretation is actually an accelerated junctional rhythm, no P waves, and an accelerated ventricular rate. So some things to take note on this EKG is that he has these really deep inverted T waves in multiple leads, okay? All over the place. But over here, he has deep T's that are severely depressed in the precordial leads. So if you were to draw a line across, you can see that there's clearly ST depression in these leads, and it's downsloping ST depression, which is even sometimes more worrisome. So you do have to worry about some type of cardiac etiology. The other thing that's of note is I want you to look at the Q restoration and the QTC. For Q restoration, we all know 222 is just too long. A lot of people say 110, 115, 120 for the Q restoration. 222 is outrageous. But even more outrageous than that is the QTC. Normally, a QTC is it's assumed to be 500 would be a prolonged QT interval for the QTC, and a 603 is for a non-ventricular rhythm. It's outrageous. It's very rare to come across one. So far we have a normal rate, regular, no P waves, some evidence of cardiac ischemia, and a severely prolonged QRS and QT interval. Now, does the patient have a left bundle branch block? Doesn't follow the traditional pattern for a left bundle, but it's certainly possible. And that's probably why Bertram's calling it a non-specific intraventricular conduction delay, because it's just not a typical left bundle branch. So let's move on and see what else there is. We have a wide, bizarre rhythm, and that should be where we can stop to start considering the diagnosis which this patient had. Anytime you think that something is big and bizarre, the first thing that could come to your mind is hyperkalemia. So hyperkalemia is referred to by one of the emergency medicine doctors at the University of Maryland who has his own EKG podcast, Amol Matu. Very good. Search him on YouTube or Google. And his podcasts are amazing. I've learned a lot from them, and so could you. But he calls hyperkalemia the great imitator, which is what syphilis was in, many years ago when it was ravaging the world. And syphilis was called the great imitator because it could really present as anything. Each person was different. People had different symptoms, different severities, and it mimicked other diseases. And that's what hyperkalemia does on the EKG. So we're going to move on and start talking about hyperkalemia. So patients that are likely to have hyperkalemia come into three big categories. You can't eliminate it. Your cells are lysing and filling your serum with potassium, or people that are just eating or drinking too much potassium. So patients that have ineffective elimination, can't pee it out, or patients who have renal failure or on dialysis, heart patients that are in failure and take potassium-sparing diuretics, and anybody who takes a lot of ACE inhibitors or NSAIDs are at risk for hyperkalemia. Then, like we said, anytime you have cellular release of potassium, including patients who have tumor lysis syndrome, rhabdomyolysis, or severe burns, anytime there's cellular breakdown, all that potassium is released from the intercellular space to the extracellular space. And DIG toxicity also brings you at risk for hyperkalemia. So there's one patient in the pre-hospital setting that is often looked over that you don't do an EKG on that could save that patient's life, or at least expedite treatment at the hospital. And the hospitals are not innocent of missing this either. So let me just say you have a 22-year-old female. She's weak and she just doesn't feel well today. She calls 911 because there's no other way to get to the hospital. It would be easy for you to miss this case. And the case is actually a diabetic in DKA. Anytime you have a patient that is profoundly hyperglycemic, weak, and has a history of diabetes or not, you should do a 12-lead EKG to evaluate for hyperkalemia. And we'll talk about the findings that you can find on the EKG. Before anybody makes fun, let me just preface this, these are my drawings, and the reason I'm showing you this normal is because it might be hard for you to figure out what's normal and what's abnormal on my EKG drawings. So just like any other EKG, here's the P wave, normal amplitude, QRS, normal amplitude, and here's the T wave. The ST segment sometimes might not line up correctly just because I'm not a very good artist. So that is a normal QRS complex that I drew. So just bear with me. So the first EKG abnormality in hyperkalemia that you could expect is a tall peaked T wave. And there's another T wave abnormality called a hyperacute T wave, which people can confuse. So we want to talk about the two differences between a hyperkalemic tall peak T and a hyperacute pre-STEMI T, or an ischemic T wave. So when you look at the top of a hyperkalemic T wave, it looks like if you stuck your finger on it, it would stick you and you would bleed. They're very sharp, very pointy, and that's very classic for a hyperkalemic T. When you think about a hyperacute pre-STEMI ischemic T, they're kind of a rounded top, not extremely sharp, and rarely come to a point. They're also very symmetrical. The base of a hyperkalemic T looks like you took the EKG, you took your finger on, you took your index finger on the left side, you took your thumb on the right side, and you pinched the base of the T wave. The base of the hyperkalemic T wave is narrow. It literally looks like you pinched it and caused it to straighten out, become longer and more pointy, and the base is narrow because you pinched it down. Whereas a hyperacute pre-STEMI ischemic T is a broad T wave base that is either normal or wider than normal. So you can see the two differences. Hyperkalemic T's, tall and pointy with a narrow base. Hyperacute pre-STEMI ischemic T, tall, rounded, symmetrical with a broad base. So that's one of the first findings that you'll find in a hyperkalemic patient. The next is you'll start to lose the P wave. So the first stage of that, so here you have a normal P. The next stage, you find that the P wave is broader and shorter. So it's almost like you put your palm down on it and you smashed it down like a bug or whatever else you could smash down. It's just shorter and kind of pancaked out, broader and shorter. And then finally, you just lose them all together. Maybe they're there, maybe there is an impulse, but it's not showing up on the EKG because it's so weak, and you essentially have what you would say is a junctional rhythm. Then finally, not that this isn't anything to worry about, of course, anytime you have EKG changes of any sort, it's something to worry about, but the kind of end of the line EKG that you find for hyperkalemia is this kind of sine wave pattern where it's extremely wide, oftentimes bradycardic, extremely bizarre, something that doesn't fit most other patterns. And oftentimes you'll look at it and you would think that if you came in on a cardiac arrest, that's where you would expect a rhythm like this to be. It looks like an idioventricular or a PEA type rhythm. So anytime you think you have something that's big, wide, tall, out of shape, or bizarre, hyperkalemia should be one of the first things that you think of. So the first case is a 22-year-old female. She's a diabetic. You assessed her glucose to be 594. She just feels very weak. She's very tired, and she would like to go to the hospital. She has no other way to get there. So when you look at these T waves, what's interesting is you can see they're they're taller than you would imagine, and they're also starting to have a slightly narrower base than you'd be used to. Um, what you'd expect in like a normal, healthy young woman, probably something more like this. There's a regular sized T, not really anything sharp or extremely out of the ordinary. But even over here, these are starting to become much taller than they were initially. And but the base is still a little bit wide, so it'd be easy to actually miss this case. If the person wasn't a diabetic and she wasn't 22 years old, you probably would never even do this EKG. And if you did this EKG on a lot of people, it would be easy to overlook these findings if you didn't have a good index of suspicion. So the other thing that you notice on here is that she has these low amplitude P waves, very kind of low, almost not noticeable in some of the leads. So at the hospital, we find that her serum potassium was 6.9. She was treated with the typical insulin and IV fluids, and the repeat EKG showed that the T waves and the P waves kind of normalized. T waves got smaller, P waves got bigger. And one thing that we're not going to discuss is at what level potassium will affect your EKG in what way. Because remember, it's the great imitator. It can do whatever it wants to different people, and because of that, you wouldn't want to be blinded by saying, well, if her EKG shows this, her serum potassium has to be 7, because it's like the old, if the person has a radial pulse, their blood pressure has to be 80, and we all know that's not true anymore. It's just the evidence doesn't support it. I've felt radial pulse on people with blood pressures of 60 and 70. Then there's other people with blood pressures of 90 that have no radial pulse. So you don't want to box yourself in by saying, well, if this person has tall peak T's but has good P waves, then it's potassium of 5.5 to 6. Because if you convince yourself that that's true, and you find an EKG like this, and you think the potassium's got to be 6, and it's actually almost 7, that's a huge difference when it comes to potassium. And of course, a potassium of 7 is much more dangerous than a potassium of 5 or 6. So you don't want to box yourself in to believing something that isn't true. So the next case we have, here's this 67-year-old male. He's at dialysis. He has a low heart rate. Not really symptomatic, but he's a little bit pale, and the staff says he's kind of sluggish. So when you print out this strip, one of the first things you notice is that there's some suspicion of a biphasic T wave. And we're not going to get into biphasic T waves in this lesson, but you have to know that oftentimes a biphasic T is something that you would suggest to be a precursor to a STEMI, especially the LAD. So you kind of see, if you draw the baseline across, you kind of see that the T wave does go up and then it goes down, which is typical of a biphasic T wave, which in the anterior leads could be indicative of a LAD blockage. So of course you do the 12 lead EKG anyway because the person has a slow heart rate. And no STEMI on there, not even a lot of ST depression. You just have that slight biphasic pattern. You clearly see that there's no P waves whatsoever, but the QRS duration is actually not very wide. It's actually pretty normal for QRS. So you would definitely call this what you would think a junctional rhythm. One thing you notice about the T waves is that they've become very sharp. Like I had explained before, it looks like if you stuck your finger on the top of that T wave, it could prick you like a needle and draw your blood. So this person had a potassium of 7.1, received dialysis, insulin, and dextrose at the hospital, and took about 4 hours before his EKG normalized. But you can kind of see, you can definitely see the sharpness here, and here especially. That is a really sharp one. And you can see that it's almost like this base is starting to come together, but these ones are still pretty wide. So remember, hyperkalemia is a great imitator. It doesn't follow every pattern ever. it doesn't follow any pattern on some people, and on other people, it's a classic textbook presentation. So you have to be very careful. They don't call hyperkalemia the great imitator for nothing. So this is the introductory case we looked at. This is the call that came in as a 67-year-old male unconscious. Turned out he wasn't unconscious. They did CPR on him for 30 seconds and he woke up. So we examine the EKG again. We do a 12 lead, and there's several things that we see on here. Let me get my little pen ready. So like we talked about before, you have this deep inverted T in multiple leads, but over here you still have that severe ischemic downsloping depressed T wave impression that would give you the idea that the patient could potentially have some type of cardiac etiology. So there's a little bit, if you look at some of the leads, my pen keeps disappearing, it kind of gives you this almost notched appearance, this RSR prime in several leads. And the reason that is I did some, like I told you, the images are a little bit poor quality for this set of EKGs. So I did some highlighting. And it just has the appearance of that because these leads cross over into each other's spaces. So because all three of these are kind of encroaching on the same place, you get this weird RSR prime in the middle lead, and you even get it over here. But I highlighted the leads for you. I can see them much better in person on my desk, and these are what these QRS complexes look like. So there's no notching or RSR prime. So anybody who wants to go in that direction can just rethink it because that's not the case. So this person's potassium was actually 8.5. He also had DIG toxicity, which could explain those deep inverted T waves. He received dialysis, insulin, and dextrose. His pacemaker was tested, and it was found to be functioning appropriately. Now, if we went all the way back to the beginning, I had mentioned that there's one thing that could be or could not be, but we weren't going to talk about them. We were going to talk about it later, and that is the pacemaker. So if we go back a little bit to the rhythm strip, this is not something that you could look at and say, oh, this, there's no way that this rhythm is a paced rhythm. And some of you that have the hawk eyes, like I said, might even see the slight pacemaker marks that are on this EKG. Right here's one. And like I said, it's so faded, I don't want you to have to imagine anything. I want you to be able to see it clearly. But like I said, I have to highlight a couple things on this to get a good visual for you. So this person does have a pacemaker. The pacemaker is firing, but it's not pacing the rhythm. So if you had seen this rhythm and there was a pacemaker spike before every QRS and the person had a pacemaker, then it would be something reasonable to think this person has a pacemaker-mediated tachycardia, or this is just plainly a paced rhythm. And that could explain all the bizarre T-wave abnormalities. However, we'll bring up this paced rhythm. So you can see the arrows here indicate the placement of pacer spikes. And they're pretty faded, a little hard to see. So I'm not inventing them. They are there, but I highlighted them for you so that you could just see the placement. Now, if you look at the placement, they don't coincide in the same place on every QRS. So here's this one where you might expect, this one you might expect to be in the appropriate place. This one, the QRS has already started before it fires, and this one fires almost during the repolarization stage. And if you look closely, I didn't highlight this one, but this one falls almost directly on the pink line. So, but when you look at it, the pacemaker is actually firing completely regularly, but it has no capture. And it's not sensing the intrinsic heart rate or electrical activity in the heart, which is what a pacemaker is supposed to do. So this pacemaker is just continuously pacing at a regular rate. but it's not sensing the heart's own activity, and it has no capture with it. But you can clearly see it. Now, if you look at this bottom strip, this is a different patient that we had recently that I don't believe had any cardiac problem, but we had him on the monitor. And you can see that the pacer spike is in the same place, the QRSs are all the same, and everything is regular, and it looks exactly like you would expect a paced rhythm to look like. If you wanted to look up more on pacemaker malfunction in the presence of hyperkalemia, there's a good article in the journal Resuscitation from 2008, and it talks a lot about the incidence of failure of pacemaker to sense and capture in the presence of hyperkalemia. So it's a very interesting article. You should probably check it out, but we're not going to go into any further about this. But like I said, this person has a pacer. The pacer is pacing, but this is not a paced rhythm. So our final case we actually had in the pre-hospital case study of grandeur for the first lesson about 6 months ago, and all the call came in was an intoxicated male that's down. You found him to be altered, but awake, or I guess I would say arousable, and breathing, but he just looked very sick. And you put the monitor on him, and you found him to be in torsades. So immediately, because it was a sustained torsades and he had altered mental status and hypotension, we cardioverted the patient. Post cardioversion, we actually thought he had arrested because the rhythm, which is now on the bottom, looks like a PEA, but he had a good pulse with the rhythm. So, like we talked about earlier in the lesson, anything that is big, misshapen, or bizarre is probably hyperkalemia. So we found out some information about the patient in that he was a chronic alcoholic, he had kidney failure but wasn't seeing a doctor, and so on and so forth. We did a 12-lead EKG, which is here. Just a very bizarre, looks like a kid took a crayon across the paper. There's no rhyme or reason to any of it. And so we go ahead with consulting medical command, and we gave albuterol, continuous, calcium, and bicarb, as well as some magnesium since he was in torsades. So after the first dose of albuterol, calcium, bicarb, and magnesium, this was his next rhythm strip. Now you can see that the rate has picked up dramatically, and the QRS has narrowed a fair amount. This is the EKG for the second one. And then this is the final EKG after a second dose of calcium, bicarb, and albuterol. No more magnesium, of course. And his EKG is drastically different. Narrow QRS, more organized rhythm. And I can't find the final 12 lead that we did, but it's similar to this bottom rhythm strip. And he does have a history of AFib, which explains this irregular rhythm that he's in, and he's non-compliant with most of his medications. But interestingly enough, he was taking his potassium-sparing diuretics for congestive heart failure regularly, but he was just in very poor health and was extremely hyperkalemic. So clinically, we gave 2 doses of calcium, continuous albuterol, so 10 milligrams. We gave 2 doses of sodium bicarb and a 2-gram dose of magnesium, and his first potassium, even after all those EKG changes, was 8.9. And 9 is like considered one of the most dangerous ranges, imminent cardiac arrest. So if you could imagine after all that treatment and all those EKG changes during transport, what his potassium must have been prior to those treatments. His magnesium was 2.6 even after the administration of the 2 grams of mag, so potentially was much lower. And his troponin was negative for any additional cardiac problems. So we gave those pre-hospital medications, as we talked about. In hospital, we got dialysis, insulin, dextrose, and more sodium bicarb, and eventually EKG kind of returned to a normal looking AFib. They were able to stabilize him, and eventually he was discharged to alcohol rehab because he had a serious alcohol abuse problem. And the last we heard, he was doing quite well. No more episodes, and he's not dialysis dependent. So that's all very good news. So the basics that this case boils down to is you have to do your EKGs. Do EKGs on anybody you think that anything could be wrong with them that's not musculoskeletal, and even sometimes that. Pulled chest muscle should probably get an EKG, especially on an older person. So any dialysis patient you put in the ambulance should receive a 12-lead EKG, just to be safe, because even if they're not calling you for that reason, there's a good likelihood that it's possible that they missed a dialysis treatment or that their electrolytes are just abnormal because they're a dialysis patient. So it doesn't hurt to do a 12 lead. It only takes a couple minutes. It's a couple stickers. It's no money out of your pocket. So doing a 12 lead on a dialysis patient could steer someone in the right direction at the hospital. Any person who has hyperglycemia that's profound or signs of DKA should get a 12 lead, because those patients are ones that it's easy to put in the ambulance and drive to the hospital, drop them off, and they sit in a room at the hospital, maybe just on a regular 4 lead for continuous ECG monitoring. No 12 lead ever gets performed, and before those first sets of labs come back, the patient could arrest. So we don't want that. Do a 12 lead, get a hint, try to see if the person is hyperkalemic based on their EKG. However, you also have to remember that a profoundly hyperkalemic person may not have serious EKG changes. So just because you do an EKG, it's just like with an MI. Just because you do an EKG doesn't mean there's not an acute obstruction and that the patient needs emergent treatment. It's something you have to monitor repeatedly and do serial EKGs. Anytime someone has a weakness, bradycardia, tachycardia, or irregular pulse, you should do a 12 lead on them. This is all basic stuff, but it's easy to forget if someone looks well or you see someone too often. And finally, always consider hyperkalemia, the syphilis, or great imitator, as Dr. Matu calls it, anytime there is a bizarre, misshapen, big, or out of place finding. Consider hyperkalemia. Thanks again for checking in. You can get to this blog by going to everythingems.info and clicking on blog. You can also go to that link, jamesemedic.weebly.com, which is the direct access to the blog. And don't forget to send me your comments, interesting cases, and good EKGs to ekgsforjames@gmail.com. Thanks again for coming down. I hope I see you next week.